Good afternoon, everyone, and welcome to the third session of our five-part series, Urology Speaks. My name is Alan Parton, and I serve as the director of the Brady Urological Institute and urologist in chief for Johns Hopkins Medicine. In a few moments, I'm going to introduce our speaker for today's webinar, Dr. John Gerhart, who will lead our talk today entitled 1,000 Exstrophies, Lessons Learned for Families and Physicians. But let me start off by wishing you all a very happy and healthy new year. I'm grateful for Dr. Gearhart's willingness to kickstart 2021 by speaking on such an important yet often overlooked topic, and feel deeply touched to see that so many of you tuned in to listen and participate. Urology in general is often viewed as a medical specialty for adult men and women who have urological disorders of the prostate, kidney, and bladder, or structural issues that have developed with age. And while we do take expert care of that population, we also play a critical role in treating patients at the very beginning of life. And here at the Brady, we've done so in a major way since 1975. I imagine that some of you may be incredibly familiar with today's topic as it has touched your family's life personally. However, I also know that some of you on the webinar may know very little or nothing at all about bladder exstrophy Epispadias complex. Wherever your knowledge level may be, I thank you for joining us and can confidently say that we will be inspired by the work and progress shared by Dr. Gearhart. Those of you who have joined us for one or both of our past two webinars heard me share the beginning of Brady. Philanthropy enabled establishment of our institute, and thanks to Mr. Diamond Jim Brady, his portrait's just over my shoulder here, he was a successful railroad company investor and a patient of Dr. Hugh Hampton Young, who was one of the forefathers of modern urology and a trailblazing physician from the Johns Hopkins Hospital. In 1915, Mr. Brady became a partner in discovery by making a generous gift to build and launch the Brady Urological Institute to honor Dr. Young's pioneering legacy and to improve the future of urological care. Now, many of you on this webinar have provided support for our mission, and I want to thank you sincerely for your partnership. While philanthropy touches all aspects of what we do at the Brady, it plays an even more crucial role for bladder exstrophy, which is funded almost exclusively by private support from our patient families. Today's webinar is being recorded, and it'll be made available to you if you'd like to pass the recording along to any of your friends or families who might have an interest in watching it. At the conclusion of Dr. Gearhart's presentation, we're going to take questions and ask that you please use the Q&A button at the bottom of your Zoom screen to ask a question. We're going to try our best to answer as many as we can. And now I proudly introduce you to my colleague and friend for over 30 years and today's speaker, Dr. John Gerhart, or as many of you on the webinar may call him, Dr. G, has made quite an accomplished career. So I'm just going to cover a few of the highlights. Dr. G came to the Brady in 1984 as a fellow and instructor in pediatric urology. In 1985, he was named assistant professor of pediatric urology. 10 years later, he was appointed the director of pediatric urology, a role he has held now for 25 years. Dr. G has led a pediatric urology division specializing in the reconstruction of major genitourinary birth defects in children. For years, patients have traveled from across the country and around the world to seek treatment and evaluation with Dr. G for their bladder exstrophy condition. A prolific writer and outstanding orator, he has contributed to more than 350 publications, authored more than 50 chapters in textbooks, and delivered too numerous to count research and clinical papers around the world. John is also a tremendous teacher. He's mentored a number of clinical and research fellows, many of whom are serving as chiefs of pediatric urology in the United States and abroad. His legacy is imprinted throughout the next generation of pediatric urologists that follow in his path, but also in the patients that he's cared for. This past year, Dr. Gerhart reached a major milestone in completing his 1,000th bladder exstrophy surgery. There's only a handful of surgeons in the country who can treat this disorder, and Dr. Gerhart's record is quite staggering. John, I now turn over the mic to you.
Well, thank you very much, Alan. It is my pleasure to be here and share a bit about the Jeff's Division of Pediatric Urology with all of our friends. So I'd like to start a little bit by just going back a little bit to the history of pediatric urology at the Brady, which Dr. Parton alluded to since 1975. Dr. Walsh became chairman at the Brady in 1975. One deficit that he recognized and immediately was a search for a full-time chief of pediatric urology. He wrote many program directors around the country saying, do you have a young faculty member that might be interested in coming and starting a fledgling division of pediatric urology here at the Brady? And he got a letter back from Toronto from Dr. Jeff saying, I don't have any young faculty members, but I got a 51-year-old guy who might be interested in coming down to Baltimore. So in typical Dr. Walsh fashion, Mrs. Walsh, in her very interesting way of doing things, found a house on the golf course at the Green Spring Valley Country Club. Mrs. Jeffs loved it. Dr. Jeffs loved it. They didn't look at another home and they moved to Baltimore. So we have to thank Peg and Pat for recruiting Dr. Jeffs down here with a home on the golf course. Dr. Jeffs was a world-renowned pediatric urologist who developed a multi-stage technique to repair bladder exstrophy back in the 70s, which has been refined over the last 10 to 15 years, which would help establish continence, voided continence in many children born with this terrific birth defect. He began a program for the treatment of bladder exstrophy in collaboration with Dr. Vern Tolo, who at that time was the professor of pediatric orthopedic surgery here at Johns Hopkins. I came along in 1984 after doing a fellowship in the UK with one of the doyens of pediatric urology, Mr. Sir Herbert Johnson, and I joined Dr. Jeffs in the practice of pediatric urology with an interest early on, and still continues to this day, in failed bladder exstrophy and the basic science of bladder exstrophy. We had a great development in 1986. Dr. Paul D. Sponseller, our current professor of pediatric orthopedic surgery here at Hopkins, joined the faculty, and Paul developed a very specific clinical and basic science interest in the anatomy of the pelvis in bladder exstrophy and the surgery of the bony pelvis in failed bladder exstrophy. And then the highlight of the whole shebang is in 2014, Dr. Heather DiCarlo joined our faculty with an interest in transitional urology and the adolescent and exstrophy patient who grow up with this birth defect. So a little bit about the background of bladder exstrophy. So bladder exstrophy epispadias, as Dr. Parton mentioned, is a spectrum of abnormalities. In particular, the most severe aspect of the bladder exstrophy spectrum is something called cloacal exstrophy. The abdominal wall is open. There's a membrane sac, which has a good bit of the intestines in it. You see half of a bladder on one side, half a bladder on the other, a very demure penis underneath, and you see a lot of the bit of the colon prolapsing out between the two bladder halves. Also, 70% of these children have some degree of spina bifida. Classic bladder exstrophy, which is here on the right, is a less serious anomaly and a more common anomaly. Here, the bladder is just open from the dome of the bladder to the tip of the penis. Okay, the ureters are here, the urine drains onto the surface, and the pelvic bones are split, and the bladder occupies the space between the pelvic bones. They have no urinary continence, no sphincters to keep them dry, and the male prostate gland is just here, right at the bladder neck. And now, as we said, it's a spectrum disease. This is penile epispadias, where the penis is open on the top, from the tip of the penis down to the base of the penis. Some of these children are incontinent of urine, and some of them do have sphincteric tissue, which can render them continent. It's a very, very interesting part of the bladder exstrophy epispadias complex. This happens about 1 in 121,000 live births. And then another rare anomaly called female epispadias. Here, there is no urethra. You're looking at the urethra open here. You can see the bladder here. There's a hemi-small clitoris here, hemi-small clitoris here. labia minora here, and a vagina here. This occurs 1 in 400,000 live births, similar to cloacal exstrophy, and all of these little girls are incontinent. So bladder exstrophy epispadias, and we're going to focus on classic bladder exstrophy today because that's really the most common anomaly, is a spectrum of rare congenital anomalies infecting the entire lower urinary tract and the external genitalia. The key salient features are the bladder is located outside of the pelvis and outside of the body. There's wide separation of the pubic bones. They're not together. The urethra is open as a plate instead of a tube, and there are no urinary control devices. Is it rare? Well, cloacal exstrophy, as we mentioned, 1 in 400,000. Bladder exstrophy, more common, 1 in 30 to 1 in 50,000. Epispadias, 1 in 121,000. And female epispadias, 1 in 400,000. And to show you how rare this is, Anthony Schaefer, who's one of our former Brady residents who went up to Boston and did a fellowship and is now at the Primary Children's Hospital in Salt Lake City, looked at this when he was at Boston Children's Hospital and did a national survey of centers that treat bladder exstrophy. And to qualify as a high volume exstrophy center, you need to do 1.7 exstrophy closures a year, and that's what the average center does. Here at Hopkins, we have the good fortune to treat 10 to 15 of these babies per year. So a major part of the birth defect in bladder exstrophy is the bony defect. Here on the left, you see the lower spine, the tailbone here are the hip joints, and you can see the pubic bones are together in the midline. In bladder exstrophy, we see that here are the pelvic floor muscles. We see that they're more distributed behind the rectum and instead of front of the rectum like they are in all of us who are normal, and the pubic bones are separated. Here you see the incisions made in the pelvic bone when the bladder exstrophy is closed to release the tension and let you to be able to bring these bones together in the midline so you can sink the bladder deep inside where these muscles can affect the child's eventual urinary continence. There's a 30% shortage of bone in the anterior pelvis in babies born with bladder exstrophy. There's just another little diagram to show you from Campbell's Urology how the pelvic bones are brought together here, how the muscles are redistributed in front of the rectum and around the urethra and bladder neck. And these are just pins that stay in for about 4 to 6 weeks while these pelvic incisions heal. So the associated birth defects are the pelvic musculature, which I showed you. The abdominal wall, the rectus muscles, your six-pack abs are separated because the bladder is on the outside, and they have males with this have an 85% chance of developing an inguinal hernia in childhood. Girls, about a 15% chance of developing an inguinal hernia. The penis is shortened by 50% and widened by 30% compared to normal males. The female vaginal length mirrors the male defect, being shorter and wider than normal ladies, and the cervix, instead of being in the dome of the vagina, is in the front wall of the vagina, very near the opening to the vagina. Other urinary tract anomalies, almost all patients have reflux of urine. This is where when the bladder fills, urine passes in the wrong direction up into the kidney, which can cause kidney infections. And the prostate, and they have a prostate, is smaller than normal, with the urethra mainly behind the prostate being mainly behind the urethra and not surrounding it like it does in normal men. So these are just some sketches from some MRI studies that we did a few years ago. This is the anterior part of the erectile bodies here, which fill full of blood when a man gets an erection. These are the posterior part of the erectile bodies, which are attached to the pubic bone. Here, a diagrammatic drawing from an MRI of a male with bladder exstrophy. You see the anterior or dependent portion of the penis is shorter than a normal male, but also a good deal wider than a normal male. So this is the big difference in genital abnormalities in males with exstrophy versus normal males. It is a lifelong birth defect. There's certain milestones that all these children need to meet. They need to have their bladder closed as a neonate or in the first few months of life. We typically repair the penis, lengthen it, straighten it when they're about 10 months of age. Then around school age, both the boys and the girls become interested in being dry of urine, and that's when they undergo a continence procedure. And lastly, in the teen years, the boys oftentimes want some more penile length, maybe some touch-up surgery to the penis, and girls like to have a little touch-up surgery to the vaginal opening so they can have intercourse and wear tampons when that's appropriate. In adult life, they certainly can have issues going into adult life, and that's Dr. DiCarlo's specialty. Certainly they can have bladder stones, they can have stenosis, where if they have a continent abdominal stoma on their tummy, which they catheterize a few times a day, sometimes the skin will tighten and they need a little touch-up surgery of that. There is a risk. We don't know the exact risk, but there is a surveillance program underway for males who may get prostate cancer and bladder cancer. Dr. H. Ballantyne Carter, as many of you know, one of our recently retired faculty members, and yours truly, have done 2 radical prostatectomies on males who developed prostate cancer who also had bladder exstrophy during childhood. So what have we learned going forward with this birth defect and how it's managed? Well, we know that there's several risk factors that can be involved with bladder exstrophy, and one is the use of in vitro technology to become pregnant. After about 15 weeks of pregnancy, a fetus voids every 90 minutes. If your wife or your daughter goes in for an ultrasound and they scan her and they don't see urine in the bladder, they should send her off for a cup of coffee or have lunch or whatever and come back in 90 minutes and scan her again. And if they don't see urine in the bladder a second time, they should at least give consideration to the fact that this fetus could have bladder exstrophy. If they diagnose or suspect bladder exstrophy prenatally, this allows for a lot of really important things to happen. Number one, they can have a fetal MRI to confirm the diagnosis on ultrasound. They can have genetic testing. We can hook the parents up with patient support groups such as the ABC, the Association of Bladder Exstrophy Community. We can also use the MRI for a differential diagnosis. As we showed you in cloacal exstrophy, sometimes they can just have a midline defect in the abdominal wall with the intestines inside, which is omphalocele, and that can be confused with bladder exstrophy. They can have a gastroschisis where the defect is to the right of the midline, still a membrane bag that has the intestines in it. Or they could have our friend cloacal exstrophy where the bladder is outside, the intestines are in a membrane bag above the bladder, and they have spina bifida. But the main importance of all this is the fact that if you use in vitro technology to achieve pregnancy, you go up to a 7.5 times risk of having bladder exstrophy in your fetus. And this work was done by Hadley Wood, one of our medical students here at Hopkins, who is now on the staff at the Cleveland Clinic. So why should you do your homework? Well, you don't want any surprises. In 2020, only about 25 to 30% of cases of bladder exstrophy are diagnosed prenatally. They miss them all the time. If they can make a diagnosis prenatally, this allows a young family to go to the internet. It offers a wealth of information from the medical literature, from hospital websites. There are centers of excellence around where they can sequester consultations from senior consultants, exstrophy team members, and there's some fabulous support groups both here and in Europe, which can help these young families deal with this birth defect and help them through the first early years of life, especially. So why should you go to a high volume center? And why is this important for a young family when they have a baby with a diagnosis of bladder exstrophy? Well, a couple of months ago in the European Journal of Urology, which is thought to be the most prestigious journal of urology, we reported 170 failed bladder exstrophy closures that have been treated at Johns Hopkins since 1975. I've had the honor of closing 138 of those. The average time to the second closure was a year of age, and that's too long. 97% of them, however, did have a successful second closure. And what was interesting is only 34% of these 170 failed exstrophies had the pelvic bones cut at the first closure. This is why you got to go to a high volume center where they have orthopedic surgeons who are well versed in the anatomy of bladder exstrophy. 76% did achieve a continence with one operation, but almost over half of those required a continent urinary diversion to become dry. But I think the most revealing thing from Dr. Kasprinsky's paper, Maddie Kasprinsky, who did this, who worked with us, is most of the surgeons who had a failed exstrophy that referred them to us had only closed one exstrophy within the last 5 years. So it has to do with experience and having a team that's busy and doing these kind of surgeries all the time. So if you have a high volume center, you have a lot of great people to help you. You need a multidisciplinary team. You need a senior experienced surgeon who's got a little gray hair, who knows about this birth defect. You need a junior faculty assistant who we're grooming to help us and to learn to do this on their own. You need a pediatric pain team, because having your pelvis fractured in 4 places and having your bladder and part of your penis put back inside your body hurts. And you need pediatric anesthesiologists who are specially trained in the management of pain in young infants. We have nurse practitioners who work on a daily basis with the pediatric anesthetist, and they have the skills to put in tunneled epidural catheters, which we leave in for 3 to 4 weeks. You ladies who have had babies and had an epidural catheter at the time of your delivery know what a blessing an epidural catheter is, and this is the same way in young infants. You need an orthopedic surgery team familiar with the pelvic bony anatomy, which can be very unusual, especially in cloacal exstrophy. They need to be familiar with performing pelvic osteotomies safely, and they need to be well-versed in immobilizing these babies after surgery so they can lie still and the pelvic bones and abdominal wall have time to heal. We're very fortunate that we have this gentleman in the lower right-hand corner, Dr. Paul D. Sponseller, who invented the osteotomy that's used worldwide today, and he is an integral part of our team and a close partner in all of these undertakings. You also need pediatric hospitalists and intensivists who can help take care of these babies for a few days after surgery till they come around and are ready to go to the floor. We have the best nurses in the world here, and I kid you not, they're experienced and they know about this disease and know how to care for it. And you need a voiding program. You need a team that's focused on teaching these children to learn to void and to learn to do a good job after they have a continence procedure. Okay. So what about advances? What have we learned in the last few years? Well, we've learned a lot. We're very fortunate here to have a great academic department. Dr. Parton has supported us. Dr. Walsh has supported our research. And within the last 5 years, we've had 42 publications within the division of pediatric urology. We've had original investigations within the division, both in the clinical and basic science area. We've written review papers for major surgical journals, and we've had collaborative research efforts with the Department of Pediatric Orthopedic Surgery, Dr. Sponseller's group, Pediatric Plastic Surgery with Dr. Richard Redette, our professor of plastic surgery, the Pediatric Radiology group, who we're still actively involved in, and our adult urology colleagues. One thing we're interested in and what we want to improve is improving the pelvic closure with new and better osteotomies. Various types of osteotomies have been offered in the past to close the pelvis. However, the world standard for osteotomies was created by Dr. Paul D. Sponseller here at Hopkins, which incises the innominate bones just above the hip joint, the iliac bones just lateral to the sacroiliac joint on both sides. And utilizing these pins, we can bring the pelvic bones together so we can put that bladder, the penis, the prostate, all down deep in the pelvis where they belong and where they can grow and hopefully be of benefit to this child when they're a little older. Something that we've developed here at the Brady with Dr. Heather DiCarlo over the last several years, which has gained some very significant interest worldwide, is to try to improve the accuracy and safety of infant surgery. So what we've done, we've taken MRIs of the baby the day before they have their bladder exstrophy surgery. And this is placed in a 3D computer-generated image. And we've done 30 patients like this. And this allows 3D visualization during surgery. And as you see here, To your right, this green is nothing more than like a wand that we can put in the pelvis. This shows us all the pelvic floor muscles. These are this pink here are the pelvic floor muscles that hold your rectum, your bladder, and all your internal organs in. You can look at these. We operate on these. Here they are in another view. Here they are in another view here, and we can look at these, and while we're dissecting, we know we're doing it safely and we're doing it completely. This has, like I said, has gathered worldwide attention, and we're now with Dr. DiCarlo nationally and internationally. We're working with a center in Saudi Arabia and another center in Manchester, the UK, to where we're going to do this. And Dr. DiCarlo is going to go over to Saudi and to Manchester. I'm going to sit in my office here with my computer, my coffee, and I'm going to telementor our colleagues overseas in doing an Exstrophy with this 3D new device that we've developed. So not only are we interested clinically in research in bladder Exstrophy, we're also interested in bladder Exstrophy at the cellular level. One of the first papers that came out of our collaboration here at the Brady was the neuroanatomy of the pelvis and bladder Exstrophy. Dr. Peter Schlegel, who's the chairman and professor at Cornell Medicine in New York, worked with me when he was a student, when he was a resident, and we were able to dissect some Exstrophy pelvis and for the first time describe the neuroanatomy of the pelvis in patients with bladder Exstrophy, which was a major step forward. We began looking at the structure of the bladder, the amount of muscle, the amount of collagen, this kind of thing back in the mid-90s. Dr. Benjamin Lee here, who is now the chairman of urology at the University of Arizona, you've heard of this Parton guy here, worked with us to look at these at the cellular level. Ron Matthews, who's the chief of pediatric urology at the University of Southern Illinois, Dr. John Gosling, who's the professor of anatomy at Stanford University, collaborated us and worked with us to look at this from electron microscopic appearance of smooth muscle cells in bladder Exstrophy. We're interested in the last few years on how these bladder muscle cells grow, why some of them grow and some of them don't. And that's a very important move forward. We've worked with Dr. Susan, who's at Detroit Children's, Dr. Steck, who's at Nemours DuPont down in Florida, Dr. Shabani, Dr. Torchy, and Dr. Kasprinsky, who's got a paper coming out in the Journal of Urology just in a couple of months, where we have identified a biological marker that may be able to share with young parents when we measure this in infancy. Hey, this is a good bladder. We think it's going to grow. It's going to be a benefit to your child. Or, well, maybe this bladder won't be as good as we like, but we're going to go ahead and really try our best to make it grow anyway. So at the cellular level, there's still a lot of things to learn with this major birth defect. Our patients grow up. And they grow up and want to be married and have kids and do the normal things that normal people do. So we're very, very focused on male sexual function, female sexual function, and dysfunction in patients with bladder Exstrophy. Andrew Baird, who's in Liverpool, who does the transitional urology for the north of England, Colonel Tim Bumgardner in the U.S. Air Force down at Wilford Hall Air Force Base in Texas, and Dr. Kelly Harris, one of our premier senior residents in urology, who I'm thankful is going to find herself a career in pediatric urology, are doing big international surveys, going to Exstrophy adults and finding out what their sexual function is, what we can do to make it better. Dr. Jennifer Miles Thomas, who's the chief down in Norfolk now, also one of our former residents, very interested and has written about female sexual function, along with Dr. Jamie Wright, our chief of adult reconstructive urology, and Dr. Everett from the GYN service here has written about the female pelvic floor with Dr. DiCarlo and myself in bladder Exstrophy. So they want to be dry. All of them want to be dry. 40 years ago, the kidneys were sacrificed on the altar of continence. They did anything to get the child dry, and they really didn't care if they harmed the kidneys or not. Continence surgery was performed as early as possible, before the child was really ready to be dry and before they could participate in avoiding program. But now we don't do that. We do continence surgery when children are cognitively mature enough to undergo reconstruction after being involved and graduating from our voiding improvement program. This is the classic Young D's Ledbetter procedure, which was developed here at the Brady by Dr. Hugh Hampton Young to render children continent of urine born with bladder exstrophy. Some bladders don't grow. Some children fail the bladder neck reconstruction. And in those children, we can add a piece of intestine to the bladder, tuck their appendix into the back wall of the bladder, and bring the appendix out through their belly button. And they'll be totally dry of urine. They'll catheterize this bladder 5 or 6 times a day, and they can play sports and they can go on about their lives and have a very good quality of life, totally continent of urine. But you have to have help. As we said, you need a multidisciplinary team, and we've got a great one. We have a void and improvement team that helps us decide which of these children are ready to be dry and which one need a little longer. Dr. Marlo Eldridge there on the left is our senior nurse practitioner who's unbelievably trained in voiding dysfunction and worldly known for her work with bladder exstrophy. We have a senior nurse practitioner trained in urodynamics who does really EKGs of the bladder muscle for us to understand which of these bladders are suitable for continence procedures and which aren't. And we have Dr. Ellen Bartolini on the right, our child psychologist, who is unbelievably helpful to these young families and helping them deal with a birth defect of this magnitude. Only at the Brady, she doesn't treat children who are abused, children whose families are getting divorced. She only treats bladder exstrophy. And this is why the Brady is unique, and this is why the Brady is a center of excellence. Well, we want to partner with the families too. A number of years ago, 1992 to be exact, we developed an IRB approved database, which of 1,383 patients. We've done 2 more exstrophies this week, so now this is up to 1,385. And this database was started by Dr. Thomas Chang, one of our gifted researchers here in the Brady, and Dr. Doug Canning when he was a fellow here at the Brady. Dr. Chang approached me one day and he said, you know, Dr. Gearhart, I think we may need to start putting all these exstrophy patients on a database. And I said, well, why is that, Tom? He said, well, Dr. Walsh has started putting all of his radical prostatectomies and his prostate cancer patients on a database. And he said, I think this is going to go somewhere. And I think this is going to be a tremendous source for research down the road. I said, well, if it's good enough for Dr. Walsh to do, I think we should do too. We started the database and it now has over 1,385 patients. And we use this for future discoveries, and we appreciate the gracious participation of all of our exstrophy families. And this is maintained by members of the urology team, including the fellows and research associates, and we go into this database on a regular basis for research projects. Well, we also want to foster a sense of community for our patients and their families. We have an online support group. The Hopkins has a support group just for the Hopkins and friends of the Brady on a Facebook page for all of our exstrophy patients. And we have an annual bladder exstrophy Epispadias picnic. It's really not as much of a picnic as it is a seminar for young parents with children. And the boys, as you see on the left with Colonel Kasprinsky there, talking to him about growing up and about becoming young men. We have the clowns that come, and then we have the parents in a beautiful room where we can share with them the newest discoveries and the newest papers on bladder exstrophy so they can improve the quality of life of all their children. Every 3 years, we offer a bladder exstrophy boot camp. This is a free, intense course that encompasses all facets of the modern management of bladder exstrophy, and this is sponsored by one of our exstrophy families. We have experts from around the nation and around the world who provide insight into their experience with bladder exstrophy and hope that the attendees, and we had over 350 the last time, will be able to implement these techniques in their own practice. Any healthcare provider, nurse, physician, pediatrician, whoever involved in the care of bladder exstrophy is invited to attend. As I said, 2 years ago, we had our last meeting. We had over 350 people, and they were from 37 countries and all around the USA. Well, we try to contribute to the literature. We've published numerous textbook chapters on the subject of bladder exstrophy. Our book there on the left, Pediatric Urology, the major text in pediatric surgery there by Puri in Dublin. We've contributed to that. And of course, the Bible of Urology, Campbell Walsh. We still have ongoing projects. We're still trying to make discoveries. We have now 124 bladder exstrophy biopsy samples growing in the laboratory and culture, working with Dr. Larissa Shimoda, who's a basic muscle physiologist at the Johns Hopkins Bayview campus. We're looking at mitochondrial networks. These are the energy producers in cells, which help the cells grow. And we're looking at the amount of collagen that are deposited in these muscle cells as maybe predictors of future growth. We're now undergoing clinical studies utilizing the 3D MRI evaluation that we use of the pelvic floor in classic exstrophy. And Dr. Kelly Harris, one of our residents I mentioned is going into pediatric urology, is working with Dr. Emily Dunn and the pediatric radiology team to look at the pelvic floor of cloacal exstrophies. We're looking at bladder growth kinetics. Dr. Waylon Wu, our fellow, clinical fellow this year, has been looking at bladder growth rates, trying to decide when is the best time to close an exstrophy. As a newborn, when they're 2 months old, when they're 3 months old, there's still some data that needs to be accumulated on that. And we're working with Dr. Tom Harris, who's one of the fellows in pediatric plastic surgery, on the outcomes of genital reconstruction in adults who've had surgery during their childhood or adolescent years. So we're all about taking care of patients, and we're all about making discoveries, but we're also about producing leaders for the field of pediatric urology. So as Dr. Parton mentioned, we've mentored, since I've been here, 35 clinical fellows in pediatric urology. 17 are chiefs of pediatric urology at major institutions in North America: Children's Hospital of Philadelphia, Brooke Army Medical Center, Dallas Children's, Duke University, Mount Sinai, New York, University of Louisville, University of Oklahoma, the Wilford Hall Air Force Medical Center, and 5 international major children's hospitals too. We've had 28 laboratory fellows who've worked with us in the Brady Ped Lab. All are currently enrolled in or completed residencies in various specialties, many of them including urology. So what can we say? Well, we've made a lot of discoveries. We've advanced the science of bladder exstrophy. We still have a way to go. We'd like to know why some bladders grow after successful closure and others don't. Why is there a 30% shortage of bone in the pelvis during fetal life? That's something that we're still working on. And does the pelvic floor musculature and getting the pelvic floor musculature together contribute to the biomechanics of continence, especially in females? And of course, improvements in male fertility. So after 36 years and 1,000 exstrophies, what are the lessons that we've learned? Well, number one, do your homework. Go to a high volume center where people are interested in this and have experience in this. Go to a center where discovery is important and discovery is underway, not just doing surgery. And I can't stress enough to all of you the importance of philanthropy to discovery. There's a lot of NIH money for cancer and AIDS and various things like that, but there's not a lot of money handed out for children born with major congenital anomalies. And that's where you all come in, and that's where we ask you to continue to support this very worthwhile endeavor. So these are 4 guys that I all had bladder exstrophy, and they all got closed the same weekend, 1 on Friday, 2 on Saturday, and 1 on Sunday. This guy's at Wake Forest. This guy is at Virginia Commonwealth University. This guy's at Virginia Commonwealth University in Virginia. This guy had just been down to Emory University, and this guy is a master wood carver in Virginia. So these are great little patients. They bring a lot of joy to both to their families and to ourselves. And it's been our pleasure to share our part of our afternoon with you. Thank you very much.
Thank you so much, Dr. Gearhart. We are now ready to pose the audience questions to both Dr. Parton and Dr. Gearhart. As a reminder, you can use the Q&A button at the bottom of your Zoom screen to submit a question, and we're going to try our best to address as many as we can. So Dr. Gearhart, I think this is a great question to start us off with. As you were going through your urology residency, what made you decide to pursue a pediatric specialty?
Well, when I was a resident, I had the good fortune of having Mr. Sir Herbert Johnson, who was one of the doyens of pediatric urology, come to Augusta. He actually came to the Masters golf tournament, but I got to spend time with him and watch him operate and see the skills that he possessed when he did children with major birth defects. And I thought, gosh, I'd like to be like that guy. And so I think that was the stimulus for me really to foster a career in pediatric urology. We all have mentors and role models, and he was certainly one of mine.
There's also a bunch of questions in the Q&A about COVID-19 and how or whether it has impacted the care of our bladder exstrophy patients. Do you think you could speak a little bit on that?
Yes, it really hasn't. I mean, certainly in March and April, they pretty much shut the Children's Hospital down. We weren't full of COVID patients, but they felt that maybe the Children's Hospital would be full of adult patients, but that really didn't pan out. And other than, the COVID testing before surgery and not being able to see as many patients as we'd like to in the outpatient clinics currently, that's really, it's been more things like that, really not, we've not had any of our exstrophy patients be smitten with COVID, the virus itself, and because it's not very common in children, but it's been mainly just the headaches of getting COVID testing and not being able to see as many patients as we'd like. But overall, we've done okay.
I think an important lesson we all learned is that fear of the unknown. When it first happened, we just shut down. We quit seeing patients. We quit operating unless it was an emergency. But when the second surge came around, we learned that testing was available. We learned when to do it, the smart way to see patients. And we've done quite well in the second surge from the standpoint of taking care of people that don't have COVID, while we still took care of the ones that did.
Absolutely. And there's also a few questions in here about or surrounding whether there is a genetic component to bladder exstrophy.
So we've done some work in that field. As you know, genetic research is unbelievably expensive. And, it's easy to get 100,000 people for genetic studies in colon cancer and breast cancer, but there's only 300 exstrophies born in North America per year. So it's not a huge amount of patients. However, that being said, working with Dr. Heiko Reuter, who is a pediatric geneticist in Germany, who happens to be one of our patients who we've worked with carefully over the years, we have looked at about 300 patients with bladder exstrophy, and we did find a deletion in the 16th chromosome. Now, that's in 300 patients, 30%. Is that the cause of bladder exstrophy? We don't know. We're interested in doing, as genetic testing gets cheaper and so forth, we're really interested in continuing that research. That's the only real finding, genetic finding in bladder exstrophy that we've had. What's really interesting, we'll make one other little thing, is that there's a nuclear plant run by DuPont over across the river from Augusta, Georgia, in Barnwell, South Carolina, which is a small town of about 20,000 people. And we have had 5 exstrophies from that little small town in South Carolina. Either the mother or the father or both parents work in that nuclear plant. And the geneticists call that clustering, where you see a birth defect they should see once every 100 years, and they see 5 within 5 years. They think that's a clustering, and there probably may be some cause and effect of that related to exstrophy, but that's the only thing that's really been reported.
Dr. Gearhart, there's a lot of questions coming through from parents who are under the care at other medical institutions. Can you maybe speak a little bit about how you educate other providers, whether it's through virtual, surgeries or whatever it may be?
Well, we all read the medical literature, and we publish fairly widespread in the medical literature, and those folks read those papers. They should, and of course they do. The other thing is as we said, the Exstrophy boot camp, which is provided by one of our wonderful supporters. We had 350 people, healthcare providers, of who 180 or so were pediatric urologists or pediatric surgeons from around the world. And they came and they had a 3-day intense course in the most modern treatment of bladder exstrophy. And that's how we reach out, and that's how we try to teach.
Dr. Parton and Dr. Gearhart, is the pediatric urology department completely separate from the rest of the activities at the Brady, or is there often a lot of collaborations between adult urologists and pediatric urologists?
Well, I can tell you it's not separate. We have ongoing collaboration with the Brady on many levels. I'll give you a prime example. Dr. Bruce Trock, who's a gifted biomedical statistician and researcher in his own right, has provided unbelievable support to our young people with the statistical analysis of a lot of the research projects that we undertake. So certainly we have been very fortunate to have any kind of collaboration we want. Dr. Pienta, all I'd have to do is ask Dr. Pienta if we needed something from the laboratory or some backup. So it's a seamless, really, collaboration in every respect.
I would totally agree with John. Our residents train in adult urology and pediatric urology. They actually rotate one month to the next from different services. The pediatric urology is part of the Brady. The Brady Institute is the mothership. John has his own battleship, and he's the captain of it, but he's certainly part of the Armada.
Yep.
So for our bladder exstrophy patients who are now adults, would they see a urologist that specializes in adult urology, or would they continue to see someone like you, Dr. Gearhart?
Well, Dr. Carl and I seem to say, and Dr. Wu, that we see children of all ages. So we see them in adult life. We're all board certified in adult urology, and we feel very comfortable taking care of adults. There are some wonderful people, Dr. Jamie Wright in particular here, who's a gifted urogynecology surgeon who helps us with our ladies when they grow up and have uterine prolapse and things like that. It really just depends on where you are and who has an interest. In many places, the adult urologists don't have an interest in treating bladder exstrophy and spina bifida patients and things like that, and the pediatric urologists take it over. But here we have a totally collaborative practice with the plastic surgeons, with Dr. Sponseller. So we take care of them into adult life. Yes, ma'am.
There's also a few questions coming through about stem cell research. Is that work being done in the bladder exstrophy space, and is Johns Hopkins playing a role in that research?
Well, we have approval from the NIH, and we completed a study using the patient's own stem cells, not stem cells from a fetus, but the patient's own stem cells in children who were not totally continent. And so we took their own stem cells and we injected them back in the bladder neck to render them continent of urine. And we had a good bit of success with that. And that research study is now closed, but may be opened again in the future.
What are the reasons that cause the stoma surgery to take place instead of a reconstructive surgery for continence?
So it has to do with bladder growth. Two things will get you an augmentation in a continent stoma. If you do have a bladder neck reconstruction and it fails and you're not continent of urine, then you're going to get a bladder augmentation and a continent stoma. Or if you have a failed closure primarily and your bladder doesn't grow after a second closure, you're going to get an augmentation and continence stoma. Or if you have a primary successful closure, but for whatever reason the bladder doesn't grow sufficiently to make you continent and protect the kidneys, you're going to get a bladder augmentation and a continence stoma. So it all depends on bladder growth.
How many surgeries does the average patient have in their lifetime? And how do you guide the timing of those surgeries?
Well, so a child with a classic exstrophy, a male, is going to have a closure in the first few months of life. They're going to have an Epispadias repair somewhere in the first year of life. And then down the road, they're going to have some sort of procedure to render them continent of urine. Now, we cystoscope all of our exstrophy patients that are waiting continence procedures once yearly to measure their interval bladder growth. That's really not a surgery, it's a diagnostic procedure. But at least 3 major operations in order to be dry. Now, girls, it's a different story. You do the urethra and the genitalia and all that kind of business at one time in infancy. And then they have a continence procedure, usually a little earlier than the boys, because girls are a little more particular about their hygiene and being dry than boys are. And then some of the girls need some external touch-up surgery about 14 or 15 when they want to wear tampons and think about boys and things like that.
John's being modest. He and one of his fellows did an absolutely wonderful study by looking at that database that he talks about. And they can actually predict, based on many variables, how big is the bladder going to get, and kind of give the family an idea whether they're going to need a lot of surgeries or a few. And they just recently had that published.
Yeah.
Dr. Gearhart, there's a question here that asks if there's such a thing as a full recovery for a young child who has had exstrophy, and if they did recover fully, would the child grow up knowing that they had the condition, or would they not know about it?
No, if it's a male child, they may have a very cosmetic, handsome looking penis, but it will still be shorter and wider than the boys they take showers with after football practice or lacrosse practice. I mean, they're going to see the difference. It's going to work just fine, but it's going to be shorter and wider than the average child. The girls, that's a different story. The girls, are going to have a lower abdominal incision, and really that's all those young ladies are ever going to see growing up. The boys, the penile issue is, you can see it. Yes.
Is there anything that a patient or a family or a provider can do to help increase or grow bladder size?
We're working on that in the laboratory. So if you look at children who are dry later on in life, there's 2 major factors. Number 1, a successful primary closure in infancy. That's number 1. And number 2, good interval bladder growth. That little bladder, once you get it inside and it can grow, it will show you what its potential is. And by the time the child's about 5 years of age, and the primary closure worked, you're going to have a pretty good predictor of whether this child's going to be able to have a bladder neck reconstruction and be dry, or need a bladder augmentation. So as I tell them, when you buy a new home, the real estate agent will say, location, near the good schools, near the good malls, near the good roads, the good churches. In exstrophy, it's capacity, capacity, and capacity. The bigger that bladder capacity is, the more likelihood that child has of being dry with a bladder neck reconstruction.
I just want to make a quick comment before we have to wrap up soon, but this is the most questions we've had on any one of these seminars. We really got a good interest. So thanks, John.
And I would like to say that if anybody has a question, email me. I'm happy to address all your questions. So jgearhart2@jh.edu. Madison can give you that address. I'll be happy to take 5 minutes and answer all your questions.
No, absolutely. And Dr. Gearhart, there are a few people in here asking, are you accepting new patients? How to get in contact with your team? So thank you for bringing that up.
We won't let him retire, so yes, he is.
Yes, we accept new patients. They can email me if they like, and I can certainly get the ball rolling for them, of course.
Wonderful. We'll take maybe 2 more questions. One is, would it be safe for someone to get surgeries this year during the pandemic, or would you recommend delaying?
I think it depends on social situation, school vacations, what the family has planned, this kind of thing. But no, we take all the precautions in the world. And I have, in fact, it's just been the opposite with us. A lot of families have said, we just want them to come out and have their surgery because they're not going to school anyway. They're going to school on a laptop. They can go to school on a laptop in the hospital. Let's get their surgery done. So it's been sort of the opposite in our practice.
I also just want to say there's a lot of comments in the chat box, Dr. Gearhart and Dr. Parton, just saying hello from all across the world and lots of cheers and compliments. So we just want to say thank you to everybody for sending those in. And we will be sure to give out the contact information in an email after this. But for our last question, how does philanthropy, impact the team's ability to go secure, large scale government or grant funding?
Well, it's helpful in a lot of ways because when you apply, as we said, a lot of, NIH money goes to cancer and inflammatory bowel disease and things like that. But they want you to have a lot of preliminary data. And what philanthropy allows us to do is to turn these young people loose, accumulate some preliminary data, and then go to philanthropy foundations, the NIH, various different people with good, solid preliminary data so we can apply for a major grant.
Agreed. Well, I'm going to go ahead and wrap us up here. Again, I want to thank you, John, for joining us this afternoon and
it's been fun.
Your research and for answering so many excellent questions. I also want to thank all of the people who participated in the webinar and especially for your continued support of the Brady and Johns Hopkins Medicine. I want to also for you to consider joining us for the last 2 sessions in our series, March 18th and June 10th. On the 18th, Dr. Andy Cohen is going to present on opportunities of reconstructive urology and designed to tailor and accelerate complete recovery. Then finally, on June 10th, Dr. Marissa Clifton, a director of our women's health at the Brady, will discuss innovations in the care and treatment of urinary continence and answer some commonly asked questions. It should be a hot topic. So I want to wish you all a safe, healthy, and promising start to 2021. Thank you all very much.